that we felt, there are lots of good courses out there, but we just wanted to do things slightly differently and make things a bit more smaller in terms of groups, and with more high yield cases and patient interaction. And that's what we really pride ourselves on. And coming up in September and October, we have various course options, which you can check out at our website, www.paces.com. The QR code's at the top right there, and the bottom right is our WhatsApp group, which you're welcome to join. And I know many of you are part of. We hold free webinars, so if you're not interested in the courses, you're still more than welcome to come along. And I know neurology is a really, really popular one that candidates often struggle with. And what I would say is that it's not as hard as you think. I think sometimes we think neurology is this really complex thing, but in the exam, they're just trying to see that you have the general skills that a medical registrar should have. So, make sure you know the common cases inside out: Parkinson's disease, multiple sclerosis, stroke, most neuron disease, peripheral neuropathies. These are the things that are going to come up in your exams. And then you might get something rare and wonderful, which, that's just luck of the draw. But as long as you approach it in a systematic way, you should be fine. But back to the courses, please do come. We try and get cases which are representative of the exam and are based on what our previous candidates have seen. You can get a discount with the code webinar20. And here's some feedback that I received fairly recently. Someone telling me that they've passed with full marks in these various stations, passed with 100%. With some Google reviews, which I'm sure you guys can check out. And yes, we'll be covering neurology today, and we'll be moving on to clinical consultation next week. So stay tuned. WhatsApp is where we post out all our webinars, so do join if you haven't already. And without further ado, I'm going to pass over to Hijaz, who's a neurologist at Guy's and St. Thomas's, so the same hospital that I work at, and hopefully can shed some more light on neurology paces for you guys. So what I'll do is I'll give you screen sharing rights.
Brilliant, yeah.
And I will leave that with you. So hopefully you should have access now.
Just have a look. Should have access now. Yeah. Can you see my screen, everyone?
Your Friday evening out. It's much appreciated.
No, it's great. No, thanks very much, Ray, for giving me this opportunity. It's teaching is definitely my passion, and I think that the way moving forward, as I think a lot of people are intimidated by neurology, when in fact I think how I approach neurology is, the advice I give generally to people is to be to have a structure to approach your examination. And I think having worked in neurology for the last 4 or 5 years, I think the best way to approach neurology is not to jump to the patient straight away, but rather take your time to observe the patient, because a lot of times your observation will already give you what a flavor of the diagnosis. So just touching base on how I approach neurology, or this, and this is the similar framework that PACES would expect you to do, is to always is to work down this pattern of starting with observation. And observation means that you stand by the end of the bed and just take your time to look at the patient without touching the patient. You can tell the patient to do something, to do some maneuvers, but you don't have to touch the patient. It's just your time to look at the patient. Tone, and this is purely for upper limb and lower limb exam, so tone, power, reflex, coordination, sensation, sensory examination. And lastly is proceed. And proceed means extra or additional examination that you would do to confirm your findings. And I'll explain to you later on as we go through our cases. So starting with observation is just look at the patient from top to bottom. And it doesn't really matter if the examiner says to you, look, can you examine the patient's upper limb? When you start to look at the patient from top to bottom, you will start to appreciate that, right, this patient, even though, so maybe the examination would be a right hemiparesis, but when you look at when you start to look at the patient's face, oh, he has a right facial droop. and he has a dysarthric speech, hyperphonic, this is quite dysphasic as well. And when you run through that, you can start to appreciate, oh, I think this is likely a stroke. So you already have a flavor of diagnosis just by looking at the patient. So top to bottom, and then especially for lower limb exam, you would want to ask the patient at the very beginning of the examination to start them to just ask them to stand up from the bed and take a walk, because you don't want to do that by the end of the examination when the time is over. So the first step you do is observe the patient and then ask them to walk. And just before they sit down on their bed or lie down on their bed again, just ask them, can you stand by the bedside, very near to the bed, bring your feet together, and close your eyes, and just test their rhomboids fairly quickly. And that makes you look slick on your examination. It looks confident. It makes you look confident to approach the patient. And then surrounding, look for orthotics, crutches, NIV machine. With NIV machine, you already have a feeling, oh, could this be a motor neuron disease? So something like that. So tone isn't something that you look for. Tone is something that you feel, and it can either be hypertonic or hypotonic. So hypertonic means that it can either be rigid, which is increase in tone throughout the entire range of motion. And that's different to spasticity, where you get this increased tone at the beginning of the movement, and then it ease off. And I think the best way to describe rigidity is if you have a cogwheel or if you have a lead pipe, just feel how it feels like it's really tight throughout the whole range of motion, whereas spasticity is like clasp knife. It's really hard for you to open the knife in the beginning, but as you open it, it gets easier. And that's spasticity. It's increasing tone at the beginning of the movement and then ease off after as the movement goes on. And lower limb check for clonus, definitely. And in terms of power, this is not strictly so we always grade power out of 5, but in paces you can say instead of 5 out of 5 or 4 out of 5, which can be a tongue twister for you, can actually say he has reduced power on the right upper limb, for example. But you have to say where exactly is the weakness. So say, for example, if the entirety of the upper limb is weak, so you can say the patient has weakness on the right upper limb throughout. But if there is distal weakness compared to proximal weakness, you have to say, right, that this patient has distal weakness of the hands and fingers, and with preserved power on shoulder abduction and elbow flexion. So say what are the muscle groups and action that are actually affected. So and that's how you describe your findings in neurology. So next is reflex. So you test all this reflex, and just to make you understand what is hyporeflexia and what is a normal. So normal means 2+, and to say whether a reflex is absent or not, you need to do an accentuating maneuver. So for upper limbs, you want to do your clenching of the teeth. So you ask the patient right before you hit your upper, so right, say for example, if you're testing their bicep reflex, just before you hit your hammer on their bicep tendon, you want to say, right, I'm going to ask you to clench your teeth. When I say so, you do so. Okay, so 1, 2, and clench, and only then you hit. So if you can't elicit a reflex after those accentuating maneuvers, only then you can say, right, reflex for this patient is actually absent. So you can't really jump from normal to absent altogether without doing an accentuating maneuver. And also, in terms of another note that I want to make is avoid the term Babinski, because it's ambiguous. So just say hunters are downgoing or upgoing. It'll be more descriptive, and it's understood universally by everyone. So that's my advice to for reflex examination. And coordination, you want to do all this. So if they ask you to do upper limb exam, make sure you do your finger to nose test and alternate pronation and supination. If it's your lower limb, make sure you do your heel to shin, and as I said at the beginning of the examination, check how they walk, and if their ROM book's positive or negative. So, and sensory examination, you need to test all four modalities. So light touch with a cotton wool, pain with a pinprick, vibration with a tuning fork of 128 hertz. You can't use 256, and proprioception beginning distally and then moving up. So these are, so cranial nerve is slightly different because you can't go through your tone, power, reflex, coordination, and sensation, like how you saw on the upper, how you do in the upper and lower limbs. You need to go through the easiest way and the framework that the PACES would recommend you to go through, all 12 cranial nerve each. And I've put here, so I'm happy to share this slide. These are the elements that needs to be examined. So going through one by one, and the most, and cranial nerve 2 would have the most element that needs to be examined, because you need to check their visual acuity, visual field, visual attention, and fundoscopy, and then move down. But these are the essential things that you have to do in your cranial nerve examination. And I'll tell you why this framework is very important once we go through the cases, because essentially what you want to do is that when you have, so essentially what you want to have during your examination is that you want to have a structure, because once you have a structure and you're used to that structure, you're not struggling anymore to think, what should I do next? What should I do next? What should I do next? Instead, you start to focus on, right, I think the abnormality is here and here and here and here. And you can start filling in as if you have a form in your brain saying that, okay, tone is normal, reflex is normal, power is reduced. So you start to fill in the blanks because you now start to appreciate the abnormalities rather than having to go through what the next step is going to be. And this is why having a structure is very important. Now, we'll start with the first case. So to say this examiner will ask you, usually they'll ask you to examine the upper limbs because it will be the easiest way to define what to define signs for Parkinson's disease. So you will start at the end of the bed and just go through and observe the patient, because so a lot of times Parkinson's is mostly an observational diagnosis. So you would start to see the patient having lack of facial expression. And if you can't find any Google image, just remember Joe Biden's face. That's a hypomimic faces, essentially. So there's a lack of expression. And then and hypophonia. And if you haven't heard hypophonia, just remember how Joe Biden talks. It's classic Parkinsonian speech, very hypophonic. And then look for resting tremor. So resting tremor is just let the patient sit down and just see how he behaves, normally. If you can't find a resting tremor, what you can do is, and I didn't put this in the slide, but what you can do is ask the patient to count 100 backwards loud. So when you start, so resting tremor is a tremor that is worse when they are distracted, and you can distract them by asking them to count 100 backwards. And then once you establish, right, there is there is a resting tremor, or especially if they're asymmetric, then you can likely say that this is likely idiopathic Parkinson's disease. So ask them to count 100 backwards. And then you can check for bradykinesia. So what you want to do is, it would be best to ideally speaking to have to show you in front. But essentially what you want to do is lift their arms forward, and you just ask them to open and close their fists as fast as they can, or tap their fingers, their index finger and their thumb as fast as you can. And bradykinesia is defined as not only slowing of movement, not only that they have a reduce in rate in tapping, but also the amplitude of tapping goes down as well as they continue tapping. So that is bradykinesia. So that's what you want to look for, and especially if they're asymmetric, you'd be able to appreciate that. You'd be able to say that most likely is idiopathic Parkinson's disease. I'll show you in the video after this. So lead pipe. So the tone now after you've established, you probably at this stage you already have a diagnosis, so you want to test the tone essentially. So lead pipe rigidity is best felt at elbow flexion and extension. You can feel the tone just just take your time just to feel the tone. It's really increased throughout the whole range of motion. And coccygeal rigidity is essentially tremor and rigidity, and it's felt best at wrist. So what you do is you want to rotate the wrist side to side, and you can appreciate that. So power tends to be normal in these patients, and you don't expect so it would be unless they have another intracerebral or a spinal cord pathology, their power should be normal and their reflexes should be normal as well. At this point, you want to do your coordination, and this is very important because if you find any signs of ataxia or past pointing or intention tremor, you want to think something more than just idiopathic Parkinson's disease. And this could be a multi-system atrophy where they have cerebellar signs or where they have cerebellar signs, and sensation tends to be normal as well. So this is where once you establish that this patient has Parkinsonism or idiopathic Parkinson's disease, you want to take this a step forward to do something that I call proceed. It's just I use the word proceed because usually it's in the consent form of surgery where we say, oh, if we find something, proceed. So it means like an extra thing you do in your examination. So what you want to test for is check for eye movement, especially if there is nystagmus, you think of MSA, or if there's vertical gaze palsy, you think of progressive supranuclear palsy. So these are the extra things. And then if you still have time, ask the patient to walk. And you can see their classic Parkinsonian gait, shuffling, narrow-based, reduced arm swing on one side, and increased tremor on the affected side, usually. So let me just show you. I have a video. So
is usually very difficult to visualize.
See how
but as you can see, and
see how the tone is increased, and you can see that it's difficult to move the joints passively. It just the way that you want to appreciate if somebody has a normal tone or not, just feel your own tone. It should feel like it should feel fluid. It shouldn't, but there is a degree of resistance to it. In Parkinsonism, they have a higher degree of resistance to passive movement. And pill rolling tremor is that tremor. So you want to look for finger tremor. So unlike essential tremor, it's usually pronation and supination, but with Parkinsonian tremor, it tends to involve the finger, and it can also involve pronation and supination. But you want to see that thumb abduction and adduction, and then index finger flexion as if they're rolling a pill. So that's your classic pill rolling tremor or resting tremor. And remember, the hallmark of resting, as the name suggests, it must be resting. It goes away with action. But so the other way, it goes away with action. So that's very important. All right. So next is, so that's case one, which is one of the commonest case you'll find in PACES neurology. So hemiparesis can be due to a number of causes, and I'll explain to you how you would go by explaining going by the differential diagnosis of hemiparesis. But essentially, what you want to look again is to just observe the patient from afar, see if there's any unilateral facial droop, listen to the speech. Try to tell you start by asking their name anyway. So listen to the speech. Start and see how fluid their speech are, or how fluent their speech is. And then if there is flexure posturing of the affected limb, like you always see in stroke patients, you almost always think that this is likely to be an upper motor neuron sign by right. And especially if it's unilateral, then you would think, oh, could this patient have something, an intracerebral pathology on the contralateral side, and then look for pronator drift as well. So pronator drift is that it's not just a drift, it's also a pronation. So you want to lift your hands forward in a supine position, and then you will see that your hands start to drift down, but also at the same time pronate as well. So that's pronator drift. And spasticity, and again, if you go to a stroke ward, you would appreciate this very much, where just try to feel the elbow flexion of somebody with stroke. It tends to get it's difficult at first to open to flex the elbow or to extend the elbow, but as you continue along, it gets easier. And then there's definitely reduced power of the affected limb. And it tends to be hyperreflexic as well. And they may not be able to perform finger to nose, but if you suspect at any point there is a degree of ataxia, then you could think of something like ataxic hemiparesis seen in lacunar stroke, but that they tend to get better over time anyway. They have reduced, so they may have also reduced light touch, pinprick, and vibration, but tend to have normal proprioception. And once you've established that this patient has has a spastic hemiparesis or an upper motor neuron cause of hemiparesis, you would have already thought, right, what are the causes of your unilateral of hemiparesis? For older patients, you want to think stroke, either ischemic or hemorrhagic as a cause, and also space occupying lesion. For younger patients, you want to think of something like multiple sclerosis or tumor as well. So give your differential diagnosis based on the patient demographic, because that shows clinical maturity of how you prioritize or how you give a working diagnosis to a patient. So, but the proceed would be feel for a pulse, because once usually this would be an older patient, so feel for a pulse. You want to see if there's any irregular heart rhythm. Auscultate for carotids or study the carotids for bruit. You want to know if there's any carotid stenosis, or look for endarterectomy scar. That would give away the etiology behind the hemiparesis. And if you see a midline sternotomy scar, you want to auscultate the heart sounds for murmur, because they could have an infective endocarditis, for example, that's caused the stroke. So you want to do extra bits. And I'm sure by the end of your practice, as you get more fluid with your examination, you will have time to do all these things. So just try to do the proceed, because it shows the examiner that you know what you're doing, and it gives you a better mark with that. So that's for upper limb. So just going through the lower limb. So again, look from top to bottom, and in terms of tone, you'd feel spastic. I'll show you in a bit what spasticity means in for lower limb. Clonus on the affected lower limb. So for clonus, what you want to do is to count the beats. All right, usually less than 2, that will be fine, but if it's more than 2, it's abnormal. Clonus tend to happen in younger patients, but for older people, they shouldn't have clonus. They have reduced power on the affected limb. They're hyperreflexic. Plantars are upgoing. Remember, we're not using the term Babinski. We're using the term plantars. Either they're upgoing or downgoing. And they may not be able to, again, they may not be able to perform heel to shin tests, depending on how severe their paresis is. And they may have reduced sensation in the affected side. And again, we'll go through the proceed, but just wanted to show you what a spastic hemiparesis look like on so just see how she's circumducting her right foot. So her right foot is internally rotated. The way that she moves her right leg is that she's circumducting. She's making a circle, a semicircle, essentially, from where she starts to push her heel, and then the way, and then where she lands is a semicircle, essentially. And you see that the knee is also rotated in. So that is a spastic hemiparetic gait, and that's very characteristic of an upper motor neuron sign. So that is why asking the patient to walk is very, very important from the very beginning, because it already gives you a lot of clue from the get-go. Right. So another case that usually can come up is Charcot-Marie tooth or hereditary sensory motor neuropathy, and this framework can also be used for peripheral neuropathy. And again, so this is why it's important to name the muscles that you see that are abnormal. So in peripheral neuropathy, they tend to affect the distal muscle first, and then they progress upwards. So you would appreciate distal wasting of distal muscles. So you see how the muscles around this area, you can see the interdigital guttering. We call it guttering because it's like a gutter essentially, and that you see muscle wasting between their between their toe muscles. And preservation of proximal muscles. So you get this inverted champagne bottle appearance in Charcot-Marie-Tooth, and high arch foot. So you see that foot there is quite high arch, and it doesn't go away when you stand up. And there's clawing of toes as well. You can see that their toes are clawed, and this is not specific for Charcot-Marie-Tooth, but you can also see them in severe diabetic foot as well. And have a quick glance at the upper limb. You don't have to go very near to the patient to look at their upper limbs, but just have a quick glance at your upper limb. They have a similar pattern of distal muscle weighting in the upper limbs, and that gives you a clue as well, because it's not merely the lower limbs that are affected, but also the upper limbs. And you can, they have, and now you've asked them to walk. So they have this characteristic high steppage, broad base gait with positive Rombergs, because in these cases, they tend to affect the proprioception. And they have usually have crutches as well. And they tend to be flaccid because these are lower motor neuron signs. They're symmetrical in distal weakness, especially on the dorsiflexion, plantar flexion, and big toe extension. They probably have absent ankle jerks, and plantars tend to be downgoing or mute or absent. They tend to have normal coordination, i.e. no cerebellar signs, even though they have broad-based gait. So I'll talk to you about gait after this. And their sensory deficit tends to be distally and symmetrical with reduced vibration and proprioception. Rarely, or they may have reduced pinprick and light touch, but not the deficit is not as severe as reduced vibration and proprioception. And in Charcot-Marie-Tooth, especially, and this is quite characteristic of Charcot-Marie-Tooth, that they have a palpable popliteal nerve. So what you want to do is you want to put your fingers at the back of their ankle or their knees, and try to feel for the nerve. It tends to run laterally and on the lateral posterior side of the ankle, and you can feel the nerve. It's bouncy. It's not as hard as the tendon, but it's bouncy. So they tend to have a slightly hypertrophied popliteal nerve. Just to show you what a high steppage gait looks like. So see how this patient, the way he lifts his leg up is higher than what an average person would walk, and see how it's quite broad base as well. So these two are what we call is ataxia, sensory neuropathy. Ataxia is essentially. So ataxia is not, it means discoordination. But what you want to know is that if this is cerebellar, or if this is a proprioceptive ataxia. The way you differentiate that is that in cerebellar ataxia, it's not just the gait that is affected, but there are also other signs of ataxia as well. And in cerebellar gait, they tend not, in pure cerebellar gait, ataxia, they don't have high steppage gait. So if you see high steppage gait with and they're broad base, and the gait is broad base as well, so think of proprioceptive deficit as a cause of their ataxia rather than cerebellum on its own. So that's a proprioceptive ataxia. They have high steppage gait because they can't orientate themselves in space, and because they have terrible foot drop, and they compensate that by putting their feet higher than usual when they walk, and they have a broad base gait as well. And their Rombergs tend to be positive in these patients. Rombergs can be positive in cerebellar as well. But remember, as I said, look for high steppage gait. If they don't have high steppage gait, but broad base, then think of cerebellar ataxia. Right. So that's Charcot-Marie tooth, and from a lower limb perspective, you similarly on the upper limb, you want to look for dorsal guttering as well. So that's dorsal guttering. Look, the best way to look is between the thumb and the index finger. You can see that there's a major muscle loss over in that area. So so those are signs of peripheral neuropathy. And again, as I said, that especially for Charcot-Marie tooth, they have a palpable nerve usually, and you can try to palpate their ulnar nerve. So where you go is just go below the medial or posterior to the medial epicondyle. You can actually feel your ulnar nerve even now. Actually, you can feel there's a bouncy string just behind the medial epicondyle. That's your ulnar nerve, but essentially they're more palpable in Charcot-Marie tooth. Motor neuron disease, so wasting of muscles, proximal and distal. So fasciculations can be easily missed if you don't take your time to look at this. This is why I stress this a bit more for neurology. It's take time to observe your patients. Take a closer look to their muscles. Look for these fasciculations, because if you missed it, you probably missed the whole diagnosis itself. And remember, as I said, it's not just, if let's say they ask you to look at the upper limbs, don't just look at the upper limbs, take a glance, listen to how they talk. They tend to have, especially in severe cases, they may have a nasal quality to the speech, or a pseudobulbar quality to the speech. I'll explain to you when I get on to cranial nerve. So look at the bedside. They may have a non-invasive ventilation or orthotics for their foot drop. And they can either be flaccid or spastic, because essentially motor neuron disease has both upper and motor neuron signs. And they tend to be weak, often begin distally and progresses proximally, and they're hyperreflexic usually. The coordination tends to be normal, and they have no sensory deficit. And this is very important because that's essentially the definition of motor neuron disease. It affects only the motor nerves. They cannot have any involvement of sensation. They can have pain, but they don't have any deficit on examination in terms of their sensation. And proceed. You can check you can examine their speech. So this is a reminder that I like to put on, that I keep on telling myself. So upper motor neuron sign plus lower motor neuron sign with no sensory deficit, always think MND. And I think this still holds true till now. So we'll just have a look at this. So this is fasciculation. So have a look. If you don't look closely, you might miss the fact that this patient actually has a tricep fasciculation. So this is why this is why you need to observe them very closely. So, and they have a heightened reflex as well. So that's hyperreflexia, because yeah. Good. Okay. If you can't see fasciculation, what you can do is sometimes you can touch the muscle, just give them a quick flick, and sometimes that can elicit fasciculation as well. Right. So lower limb examination. So again, just observe the patient, looking for any muscle wasting, fasciculation. In this one, you have to really look closely. And again, just give a quick glance to your upper limbs as well. They may have the same issue, and they tend to be high steppage and spastic gait, or they're not. And in severe cases, they may not be able to walk at all. And again, this time their gait is not. They're not broad-based. It's just that they have high steppage because of foot drop, and they might have a non-invasive ventilation, as we spoke about. Again, similarly, the framework still stays the same. Can be flaccid or spastic. They tend to have clonus, which are positive, and they tend to be weak. That begins distally and progresses proximally, and the rest are the same. And plantars tend to be upgoing. So this is a fasciculation of the hip. if you see the quadricep muscles, it's very subtle, but it's there in the medial side of and again, this just stress the point that you really have to look closely for these. So cranial nerve. So another popular examination for cranial nerve is bulbar palsy or pseudobulbar palsy, and I'll explain to you what the difference is. So they tend not to have any change in smell nor change in their visual fields or acuity, and they tend to have a normal examination in their pupils. And one of the hallmarks of motor neuron disease is that extraocular muscle movements tend to be spared in motor neuron disease. They tend not to be involved. So if you see any eye, if you see any involvement of eye movement, think something else than motor neuron disease. Something like myasthenia gravis, or something like myasthenia gravis would be the differential for patients who look like as if they have motor neuron disease, but actually because of their extraocular muscle movement, they can't be MND because they tend to be spared in MND. So think something else like myasthenia gravis. They tend to have a normal facial sensation, but a brisk jaw jerk, which I'll show you later after this. They have symmetrical facial muscle weakness, which can be upper or lower motor pattern. And they have so this is where it's the cranial nerve 9 and 10 is where it's quite important. So in bulbar palsy, the speech tends to be nasal quality, as if somebody is having a flu. In pseudobulbar palsy, the speech tends to be slow, grunting, as if somebody has just eaten a hot potato, essentially, as if there's hot food in their mouth. So that's a pseudobulbar speech. In that palatal paralysis, you need to have a look at their uvula and shining a light to the back of their throat. They have weak trapezius and sternocleidomastoid with wasting and fasciculations, and you can't try to look at their back and observe the tongue for any wasting, fasciculation, or spasticity. So this is an image from New England Journal, and that's your tongue fasciculation, as if it's, well, the tongue is essentially a muscle, so you would expect fasciculations if they have a bulbar palsy. So another note that I want to make is that bulbar palsy is essentially lower motor neuron. Is essentially a lower motor neuron pathology. So you would expect fasciculation, you would expect wasting of the tongue, you would expect a nasal quality to their speech. So these are features of bulbar palsy. Pseudobulbar, the tongue tends to be spastic, and this is a patient with a bulbar palsy. So see how it's hard for them to protrude their tongue, but their tongue muscle bulk seems to look normal from this angle. And just listen to this patient's speech. See, as if he's eaten something really hot. So look at the jaw jerk. It's brisk. Usually you won't be able to elicit anything, but that examiner is able to elicit a jaw jerk, so that means it's brisk. So look at the tongue. There's no fasciculation. Tongue bulk seems to be really good, but it's hard to protrude. There. Yeah, so that tongue looks spastic.
Easy to gag, isn't it?
Yeah. Okay. So that's a pseudobulbar palsy or pseudobulbar sign. All right. So and again, just to reiterate, it's an upper motor neuron finding. Case 9, which is a myasthenia gravis. So I'm sure at some point everybody has seen hopefully have seen a myasthenic patient, but the hallmark of myasthenia gravis is that it needs to be fatigable. So they tend to have normal visual acuity, but they tend to the ptosis is fatigable. So what you want to do in these patients is that when you're examining their eye movement, ask them to look up to your finger for give them a few seconds, and as you continue to hold your position in an up towards an upward direction, you will start to appreciate that the ptosis gets worse and your diplopia gets worse as well. So that's a fatigable ptosis and fatigable diplopia, which is one of the signs for myasthenia gravis. And there's weakness on jaw opening. So what you want to do is you want to ask them to open your mouth, and then try to push again. Then ask them to keep opening, and you try to resist that. To resist the action of you trying to close it. Again, they may have bulbar or nasal. They tend to have bulbar signs, not pseudobulbar, because remember, myasthenia gravis is a neuromuscular junction pathology, so they shouldn't have any upper motor neuron signs. So they have a nasal quality and dysphonia. And what you want to do is you can ask them to just count 1, 2, 3, 4, 5, 6, and you will appreciate the decrement in volume of their speech as they continue to count. You can have weak trapezius and sternocleidomastoid. Check their neck flexion and extension, because neck flexion correlates with diaphragm. Weakness in neck flexion correlates with weakness in diaphragm. So in clinical practice, if somebody has a weak neck flexion, they may be at high risk of developing diaphragmatic weakness. They can have tongue weakness, but that's usually not common. So what you want to do at this stage is that even though this is a cranial nerve examination in myasthenia gravis, you would want to take your time to examine the proximal muscles. So test for shoulder abduction. And then what you want to do, if the power might be 5 out of 5 initially, what you want to do is ask them to abduct and adduct their shoulders for 20 times each side, and then test that power again. And you will see that the power will now start to reduce, maybe to 4 out of 5, from 5 out of 5. And that's the fatigable proximal muscle weakness. You want to percuss their anterior chest to see if there's any dullness, because if there's dullness, it could indicate thymoma. See if they're Cushingoid, because they tend to be on steroids, and check for anterior chest scars, because they might have a thymectomy done previously. So these are the proceeds or the additional examination that you want to do for myasthenia gravis. And again, you'll score higher points if you do these things, because this shows that it indicates to the examiner that you know what you're looking for. So I have some eye signs here, but so that's a Cogan sign. So remember, ptosis in myasthenia gravis can be asymmetric. So, and it's common to be asymmetric as well. So don't be bogged down if you see an asymmetric ptosis, because they can be. So abduction and adduction looks all right right now, but see how if you hold them long enough, the ptosis gets worse, especially you can appreciate on the left side. And then you can see partial ptosis now sets in because he's had his movement a lot for a long time. See how his ptosis now gets worse because it's fatigable at this point. And these are just some signs that I don't want to load a lot, but with other miscellaneous signs in myasthenia gravis of no clinical or no or little clinical utility. So unilateral foot drop is the last bit, I'd say. So this is a common thing that you'd encounter as well in PACES exam. So muscle wasting, especially at the anterolateral compartment of the calf, and their gait tends to be a unilateral high steppage gait. If you see somebody with a unilateral high steppage gait and also circumducting gait, then that foot drop cannot come from common peroneal or L5 pathology. It can either come from the spinal cord or the brain, because essentially that's an upper motor neuron sign. So in a pure lower motor cause of foot drop, either from L5 L5 pathology or a common peroneal pathology, you would expect their tone to be flaccid, especially on the affected ankle. Now, these are discriminatory findings, how to differentiate between L5 and common peroneal. If you see hip abduction weakness, then that's likely an L5. Ankle inversion sparing would be common peroneal nerve. Weak dorsiflexion and ankle eversion are seen in both common peroneal and L5 neuropathy. They tend to have both. They both tend to have normal ankle jerk, because ankle jerk is essentially S1 and S2, so they won't be affected. They have normal coordination, reduced in light touch at the lateral side of the calf or dorsum of the foot. And in L5, so the additional examination is you want to do a straight leg raise test, because if somebody has a disc herniation impinging on the L5, then that's likely the cause of it, of the foot drop. You want to examine their back for any surgical scar and palpate the head of fibula, because sometimes in common peroneal nerve palsy, you can get tenderness over over the head of fibula, because you get entrapment of the common peroneal nerve. Especially in patients who have lost weight over time, they tend to get entrapment in that area, which causes the common peroneal nerve palsy. And another thing is I've got to add is you want to look for orthotics for foot drop. I think that's all from me. I think so. What I've given you today is an approach to hopefully a brief overview to how you would proceed with your examination. I didn't put on any factual things that they would ask you after your examination, because I thought you can read that on your own time. But I think if there's anything in terms of what your take-home message is to have a structure and fill in those blanks. Once you have a structure, fill in those blanks based on your findings from exam, and then you can formulate a diagnosis or differential diagnosis based on that. So hopefully this is helpful, and Shoaib, I'll give the floor to you, and if there's any questions, I'm more than happy to take.
Hey, thank you so much. That was really, really good. I hope my connection is a little bit choppy at the moment, so I hope I'm not dropping off. But I think that was a super useful overview of like really common cases that you guys will definitely see. And actually just going through some of those are cases that potentially, you know, some of you already sat cases may well have encountered. And actually some that we have on the course. So thank you so much for that. That was actually fantastic. And I'm sure the audience really enjoyed that. We have almost 50 of you tuned in. Just shows, you know, on a Friday evening what a popular topic neurology is.
Yeah.
But hopefully we've kind of deconstructed some of it for you. Well, not we, I can't really take any credit, but yeah, hopefully we've simplified things a little bit. If you have any questions, just drop a message in the chat. I think some people are.
Can you show me?
Might be if you know what I'll do is, if it's okay with you, Mohammed, can I just post the slides in the WhatsApp?
Yeah, please. These slides are I made them, but I'll give it to anybody who needs them. Really,
amazing. Yeah, I think rather than you having to go through the cases again, it might just be easier if we just posted the slides in the chat. I think this is actually a really good question. Why examine the back for surgical scars? So
so you want to look for any, if they have a discectomy done or laminectomy done, the scars can be really tiny and they can be really concealed. So they're about 5 centimeters only. So you want to look for that scar, especially at the lumbar region, and that gives you a diagnosis as well. Because if somebody has a scar at the back, you could think, this could be an L5 disc herniation. So for the foot drop.
And I think that's the case that I had in my exam. So I had a guy who had basically bilateral lower lip uppermost neuron signs, and he had a cervical neck scar, and he obviously had what I thought was cervical spondylosis with myelopathy, and that turned out to be the case. So very important to examine for scars.
Yeah. Stone in Charcot-Marie tooth. So remember, Charcot-Marie tooth is a peripheral neuropathy, so you don't expect to see a upper motor neuron sign. So hypertonia or spasticity is an upper motor neuron sign. So you would expect them to be flaccid or hypotonic, so reduced tone essentially.
Fantastic. I think that's probably the bulk of the questions. So what I'll do is I'll post the slides in the chat, guys, and you're welcome to access them there. Please do join our WhatsApp group. Check out our upcoming course. We do have spaces, a few left for September, and we have spaces for October. And hopefully we'll catch you at our next webinar on clinical consultation. And a big thank you to Mohammed for doing the webinar on a Friday evening as well. You know, I'm sure he has much more exciting things to be doing, so it's much appreciated.
No, it's fine. I think there's a bit two more questions. So no
Sure.
orange stick. So planters, I would what I tend to do with planters is that so in PACES, I would try to encourage people to bring their own items as well. So what you want to do is you can bring an ice cream wooden stick, or you can use the back of your tendon hammer because it's sharp. Well, it's not as sharp. It's dull sharp sort of feature. So you can use that. SLR interpretation, if so, straight leg raise test in a normal person, it should be more than 45 degrees or up to 90 degrees actually in a normal person. But if you can't do anything above 45 degrees, then you have a positive straight leg raise test. And the reason why is that straight leg raise test is, if it's positive, it's indicative of a lumbar nerve root impingement. Right.
Fantastic. Should we wrap up there?
Yeah, definitely.
Everything. All right. Thanks a lot, Mohammed. Thanks
very much, everyone, for joining. Best of luck.
And we'll see you at the next one. Take care.
See you.